Hi, I'm Dr. Henry de la Cruz, and today we're going to talk about relevant issues on antimicrobials for common respiratory diseases in the adult. Through this session, we'd like you to be able to recognize common respiratory diseases and apply rational drug use, that is, to prepare therapeutic goals, choose the appropriate medication with regard to the pharmacodynamic and pharmacokinetic principles, advise patients on the monitoring and evaluation, and in general, these measures will avoid irrational use of antimicrobials. The World Health Organization estimates that half of outpatient antimicrobials are considered irrational.
If we apply rational drug use for antimicrobial choice, we will limit ourselves to efficacy, safety, suitability, and cost. In antimicrobials, however, it is important to also consider host factors and microbial factors. Host factors include in the presence or absence of immunocompromise, which may require stronger doses or higher generation of antimicrobials, the presence of comorbidities which may affect hepatic or renal clearance, genetic polymorphisms that make your antimicrobials better selected for some rather than others, accounting for interindividual variations. Microbials may be affected by the site of origin. Community-acquired infections may require basic antimicrobials, but nosocomial infections may require higher combination or higher dose. Resistance and virulence factors can determine whether the antimicrobial required will be of a higher generation. The combination of the host, the drug, and the bug considerations will help to rationalize the selection of your antimicrobial.
To study for this session, we're going to review the various antimicrobial chapters in Katsung, which will span the cell wall inhibitors, plasma membrane inhibitors, ribosomal 30S or 50S subunit inhibitors, metabolic pathway inhibitors, and DNA and RNA synthesis inhibitors. Other helpful references for the session will include the National Antibiotic Guidelines of the DOH for 2018, recommendations from the Center for Disease Control and Prevention, American Family Physician, and Infectious Disease Societies of America. Let's take a fairly common case. If one of your peers tells you that after studying for several nights with poor sleep, he has sore throat, runny nose, whitish nasal discharge, and a dry cough. He takes paracetamol for a moderate grade fever. What would be your impression? And how can you help manage this patient? Let's look at the most common respiratory diseases associated with acute cough. In considering the various differential diagnoses of cough, the American College of Chest Physicians will remind us that it's important to have an idea of the timeline whether a cough is acute, less than 3 weeks, or subacute, 3 to 8 weeks, because their etiologies will be different from chronic cough lasting more than 8 weeks. For acute cough, it's important that there are non infectious causes such as your asthma COPD, congestive heart failure, pulmonary embolism, pneumothorax, acute interstitial pneumonias. The history of inhaled foreign bodies or toxic fumes might give you an idea. And this can differentiate from infectious causes. Among the infectious causes, it's important to distinguish viral upper respiratory tract infections, which are most common in the outpatient, versus bacterial tracheobronchitis and pneumonia. For subacute cough, consider that there may also be post infectious cough syndromes, which do not require antimicrobials. Subacute cough can be present with pertussis. Chronic causes of cough are likewise differentiated in terms of having underlying conditions such as asthma, upper airway cough syndrome or postnasal drip, GERD, use of ACE inhibitors, post infectious cough, and COPD. And they should be differentiated from cough caused by interstitial lung diseases and cancer, whereas an infectious cause that causes chronic cough can be your tuberculosis. Knowing the different spectrum that can be a differential for cough is important before we leap into antimicrobials. If you recall from your anatomy, the larynx is the borderline between the upper and lower respiratory tract infection. Your upper respiratory tract infection is predominantly viral. 80 to 90% of infections in the upper respiratory tract are viral. Many physicians, however, more than 60%, will prescribe an antimicrobial in an outpatient consult. Next to the common cold, the flu, other localized upper respiratory infections, including your pharyngitis and tonsillitis, comprise the majority of upper respiratory tract infection consultations in the outpatient. What is important to note is that the common cold, acute rhinitis, is 85 to 90% rhinoviruses, coronaviruses, adeno, mixo, echo, coxsackie, echo, mycoplasma, or chlamydia. Other upper respiratory infections are also prone to adenovirus, herpes simplex, and coxsackie in the pharynx. In your sinusitis, strep pneumonia, and H. influenza are more common. Croup and epiglottitis, which are more of childhood um, respiratory conditions, are mostly due to H. influenza and parainfluenza. We'll look at the other lower respiratory tract infections in a while. Having reviewed the common causes of upper respiratory infections, we know that those who present with symptoms of the common cold with nasal discharge, fever, or nasal congestion, there's no need to treat the patient. Symptomatic management with analgesics, hydration, possibly decongestants or lozenges that will help to relieve symptoms can be used, but there's no room for antimicrobials in the treatment of symptoms of the common cold. Apart from viral acute rhinitis, a common differential will be rhinitis secondary to allergic reactions. In seasonal allergic rhinitis, the release of pollen, for example, may be a trigger for seasonal allergic rhinitis. Dust mites and pet dander are more commonly found year round and therefore they may induce perennial allergic rhinitis. Smoke and strong odors are considered non allergic type. What's important is that the runny nose, sneezing, congestion, and sinus pressure will mimic your viral rhinitis. Considering the possibility of allergic rhinitis will allow you to select the types of antihistamines that are more appropriate for this type of rhinitis. Another differential for cough will be upper airway cough syndrome, formerly known as the postnasal drip. Postnasal drip has been expanded to include other causes of upper airway cough, and this includes allergic, non allergic, vasomotor rhinitis, acute nasopharyngitis, and even sinusitis. Therapies for these differentials may include measures that will not need antimicrobials, including oral and nasal antihistamines, decongestants, or oral leukotriene receptor antagonists. For acute relief of postnasal drip, first generation antihistamines will be preferred over the second generation antihistamines because of their stronger anticholinergic effect, but limiting their use of first generation will be sedating effects. There will be no place for antimicrobials if it is only due to non infectious causes. Symptomatic treatment for upper airway cough syndrome and allergic rhinitis may not require antimicrobials. Instead, anti inflammatory agents or nasal decongestants may be used. It's important that when you use your intranasal corticosteroids, that there are several options such as your ciclisinide, fluticasone, or mometasone nasal sprays. Prolonged use, however, may lead to a condition called rhinitis medicamentosa, where there is cobblestoning and thickening of the respiratory epithelium, which can lead to nasal obstruction and life threatening uh, airway compromise. Other non infectious causes of cough include your gastroesophageal reflux disease or cough variant asthma. Your GERD typically presents with your symptoms of hyperacidity associated with retrospinal pain and is typically triggered after a very large meal. The importance of distinguishing your GERD will be that the management will not be through your cough medication, but by suppressing your acid secretions via your protein pump inhibitors such as your omeprazole. Weight loss and dietary modifications to decrease acids in the diet will be helpful. In cough variant asthma, a history of an hypersensitivity or a family history of asthma may be prominent, and their presenting symptom will be persistent and uncontrollable spasms of cough, which are typical of your reversible airflow obstruction. The patient may be diagnosed by bronchial stimulation, and for these patients, your typical bronchodilators and corticosteroid combinations may be helpful in the period that the patient is suffering from uh, attacks of your cough variant asthma. But unlike asthma, these medications do not require maintenance unless the symptoms are really persistent. It is important to distinguish the common cold from flu. Though there are many overlapping symptoms, flu will present with a higher and more persistent type of fever associated with more systemic symptoms, more severe body ache, fatigue and weakness, and prominent exhaustion, and more common chest discomfort. Complications of your influenza may be your bronchitis or pneumonia, whereas in the common cold, which is milder, the complications are more commonly your sinusitis and ear infections. While normal individuals may get 3 to 4 upper respiratory tract infections within a year, the presence of influenza outbreaks may cause an increase in the number of patients, causing a widespread type of infection, which we now are very familiar with as a pandemic. Your influenza can be distinguished from your common cold by the presence of two surface proteins, the H and N proteins, hemagglutinin and neuraminidase. And when we review the history of pandemics, many of these pandemics were due to the influenza A type of uh, virus. In 1918, the Spanish flu, which caused 20 to 40 million deaths, recurred in 2009 as the swine flu. In the last Hong Kong flu in 1968 and 1957, the Asian flu, a million deaths were due to H3N2, while the avian flu uh, presented with H5N1 and H7N9 in Pampanga, Nueva Ecija, and in your Bulacan. No, these were the strains that caused avian flu transmission to humans. Swine flu in 2009 caused drug resistant type of flu pandemic. We are warned that a more widespread flu pandemic is due to be an outbreak causing a pandemic in the near future. Influenza B is also a differential in the flu outbreaks, but these tend to be more self limited. The B type of virus was more has been on the rise in the Philippines in the past years, but this causes mild self-limiting infection, usually associated with uh, systemic symptoms, including your diarrhea. People who are at greater risk of complications will be those in the very old or very young age groups where you have immunocompromise from either underdeveloped or degenerating immune systems. Pregnant women and those with chronic medical conditions, whether it is hepatic, cardiac, renal, pulmonary, or metabolic, neurodevelopmental, will also be at risk. Patients who are immunosuppressed and those who are highly exposed to many cases, such as your healthcare workers, are those who are at greater risk and may require prophylactic uh, treatment upon exposure. The treatment and prophylactic drug of choice for flu will be your oseltamivir or the local spray, locally acting nasal aerosol inhaler will be your zanamivir. Both are neuraminidase inhibitors, which act by inhibiting the release of your virions from the infected cell. You remember that because their mechanism is to inhibit release, they should be given within the first 2 days of onset of symptoms for it to be more active. S- This is generally well tolerated, but it may also cause some bronchitis, insomnia, nausea, GI disturbances. The use of oseltamivir, however, should be limited to those who are at risk of greater complications, the very young and very old, immunocompromised, and healthcare workers who are more highly exposed to the effects of the drugs. Because aside from the benign complications or adverse effects that we have mentioned, there are also more serious adverse effects such as your delirium, hallucinations, unusual behavior, or self injury associated with this drug. Long before the current pandemic, World Health Organization already provided Important advice for preventing aerosol transmission of your flu virus, coming up with the three C's to cover your cough: clean and disinfect your hands with frequent hand washing, and contain or isolation of those who are sick. In this new pandemic, the three C's are also similar to the previous preventive advice, which means that you can prevent transmission of aerosol infections by avoiding the three C's: confined and closed spaces, crowded places, and closed contact settings. So far, we've talked about many of the viral infections, and we saw that only a few require treatment with antimicrobials. In this next slides, we're going to look at upper respiratory tract infections which require antimicrobials to treat the condition. Acute rhinitis, allergic rhinitis, or the flu may be distinguished from rhinosinusitis. This is a more serious condition that may complicate into mastoiditis or severe infections. These criteria to distinguish bacterial from viral sinusitis include the onset of symptoms that lasts for more than 10 days, the persistence of high fever, purulent nasal discharge or facial pain, or worsening of symptoms, which may be uh, the progression of fever, headache, increase in nasal discharge following the typical viral infections, as double sickening or worsening after an initial improvement may be an indication for antimicrobial use as well. Common pathogens causing sinusitis may include both aerobic bacteria such as your Strep pyogenes, Staph aureus, and Haemophilus influenza, but also anaerobic isolates including Prevotella, Porphyromonas, Fusobacterium, and Peptostreptococcus. Phenoxymethylpenicillin has been recommended as a first line for sinusitis in patients who are otherwise well or have no history of prior antimicrobial use. If the patient is more ill or at high risk of complications, amoxicillin clavulanic can be the option. For penicillin allergy, the tetracycline doxycycline or the macrolides clarithromycin or erythromycin has been recommended. Penicillin is a drug of choice for many conditions. One of the oldest drugs, it covers not only gram-positive organisms but also includes helps E. enterococci, Haemophilus E. coli, Listeria, Proteus, and Salmonella species, including also your enterococci in its spectrum of activity, making it a useful drug for many of your upper respiratory tract infections. 10% of patients who have penicillin allergy may also have cross reactivity with cephalosporins. But for those who have prior intake of cephalosporins, this can be an option for penicillin allergic patients with sinusitis. And among the options that are available for sinusitis, you may have first generation options such as your cefalexin and cefadroxil, which offer broader spectrum. Cefuroxime increases the gram-negative coverage further, being a second-generation cephalosporin. Third-generation oral cephalosporins that may be helpful in sinusitis include cefpodoxime, cefdinir, and cefixime. When there is any contraindication to penicillins or cephalosporins, or when macrolide resistance is a concern, The option can be lincosamide, such as clindamycin, which is a broad spectrum antimicrobial with anaerobic coverage. If you will recall, however, it has prominent adverse effects in the GI, including your nausea, diarrhea, a metallic taste in the mouth, some hepatic uh, elevation of your transaminases. Bacterial pharyngitis will be more commonly due to your strep pyogenes, and unlike your viral presentation, the physical findings are important in bacterial pharyngitis. When you look into the patient's oral cavity, you'll see that the tonsils are more hyperemic than viral infections, and the exudates are more marked, accompanied by tender or enlarged anterior cervical lymph nodes, petechiae in the palate, and the absence of cough. Your strep etiology can be confirmed with your rapid antigen diagnostic tests. Your rapid antigen detection test can give you immediate results, and the drug of choice for those who are confirmed will be your penicillin G or your penicillin V, uh, or amoxicillin as in the empiric antimicrobial therapy. Alternatives can be the cephalosporins, clindamycin, or your macrolides. For recurrent pharyngitis, the agent will remain to be group A streptococci. True group A streptococci can be difficult to distinguish from the carrier states with repeated viral pharyngitis. But again, if we apply the same criteria, we will be able to distinguish the bacterial etiology. If the treatment of choice will not be different, and phenoxymethyl penicillin or penicillin V and broad spectrum amoxicillin will remain the first line. But second options will be your cefuroxime, which will include increase the gram-negative coverage, and co-amoxiclav or amoxicillin clavulanic acid, which will increase the spectrum of your amoxicillin. A serious complication of exudative pharyngitis can be the presence of peritonsillar abscesses, which can be life-threatening. Surgical drainage is often required, and the etiologic agent will include mixed bacteria, including your Fusobacterium, group A streptococci, groups C and G streptococci, and Streptococcus aeruginosus group. Considering the broader etiology, the medication of choice will be ampicillin sulbactam or amoxicillin clavulanate. Second line will be ceftriaxone with metronidazole. The addition of metronidazole will be to increase your anaerobic coverage. So far, we've been choosing antimicrobials according to their spectrum, but it's also to remember that the choice of antimicrobials will also pay attention to the need for bacteriostatic versus bactericidal activity. Remember that bactericidal activity will be directly toxic to the organism and produce a more immediate effect, while bacteriostatic agents will allow your natural defense mechanisms to eliminate the organism. Quick acting bactericidal agents can be remembered by the mnemonic very finely proficient at murder. Vancomycin, fluoroquinolones, penicillins, aminoglycosides, and metronidazole are effective cidal drugs, while static drugs will include those that are ecstatic, erythromycin, clindamycin, sulfamethoxazole, trimethoprim, tetracycline, and chloramphenicol. An important differential for cough persisting 2 to 8 weeks will be pertussis. The agent Bordetella pertussis was once considered an eradicated infection, but more recent sporadic cases have been appearing globally, including the Philippines. The pathology is due to pertussis toxins, which allows the bacteria to persist for prolonged periods in the respiratory tract due to multiple effects on immune cells. Its immunosuppressive function is related to its inhibition of macrophages, neutrophils, dendritic cells, and T lymphocytes. A related toxin will be the adenylate cyclase toxin, which is capable of inhibiting the phagocytic function and uh, increasing your cyclic AMP, resulting in paralysis of the phagocytic function of neutrophils and dendritic cells. The production of adherence factors such as your filamentous hemagglutinin agent will inhibit your neutrophils and T lymphocytes from phagocytic functions. The typical presentation of pertussis is your catarrhal stage, which is a non-specific mild infection with cough, rhinorrhea, some conjunctival suffusion, and excessive lacrimation, followed by a more severe paroxysmal stage where you can have the symptom of your paroxysmal or whooping cough, which will uh, give you the diagnosis. Inspiratory stridor may be particularly prominent in this phase, and in children, it becomes very problematic because the nutritional compromise can cause secondary infections at this stage. The convalescence phase can ensue even without therapy, and the convalescent stage is characterized by gradual reduction in symptoms over 1 to 2 weeks. Treatment with macrolides like your erythromycin, azithromycin, and clarithromycin can limit the duration of your infection. Like pertussis, diphtheria is a re-emerging disease previously considered eradicated. Sporadic cases are now being observed globally. The agent Corynebacterium diphtheria is an aerobic gram-positive bacteria spread through respiratory droplets. The hallmark of this disease will be the production of a toxin which inhibits protein synthesis and destroys local tissue. When you look into the tonsils of a patient with diphtheria, there is the characteristic appearance of a pseudomembrane consisting of destroyed tissue within 2 to 3 days of illness, lining the tonsils, pharynx, larynx, or nares, and extending into the trachea. This pseudomembrane, should not be attempted to be removed. Fatal obstruction can result when the pseudomembrane extends into the larynx or trachea. The toxin can spread from the tonsillar area to various organs, causing myocarditis, polyneuropathy, or renal failure. The typical signs and symptoms will begin with fever, sore throat, and neck swelling, but will rapidly progress and cause multisystemic problems. Diphtheria treatment includes the administration of an antitoxin, giving penicillin or erythromycin over 2 weeks to eliminate the bacteria and prevent its transmission using an IV preparation. And it's important to immunize the patients even during the recovery phase because not all patients develop the protective immunity. Routine vaccination of diphtheria should be given to children at 2, 4, 6 months of age, and a second and third boosters at 15 to 18 months and 4 to 8 years. As we review various respiratory conditions requiring antimicrobials, it will be also important to pay attention to the spectrum of antimicrobials. The rule of thumb in antimicrobial use is to target the organism and use the appropriate antimicrobial with the narrowest spectrum of activity specific for the agent. And for gram positive bacteria affecting the respiratory tract, penicillins, first generation cephalosporins, vancomycin, linezolid, and daptomycin can provide more focused gram-positive cocci coverage, while expanded coverage of gram-positive and negative organisms can be achieved with the broader spectrum amoxicillin, amoxicillin clavulanate, or extended spectrum penicillins. Remember that extended spectrum penicillins and amoxicillin clavulanate may have anaerobic coverage. The carbapenems can cover a wide range of organisms, ranging from your gram positive to your anaerobes, and are therefore reserved for the more serious infections. More specific gram negative antimicrobials can be your trimethoprim, your fluoroquinolones, and your aminoglycosides. Anaerobic coverage can be achieved with clindamycin, metronidazole, extended spectrum penicillins, and fluoroquinolones, as well as your carbapenems.